Hello, ladies and gentlemen. This will be a talk on the ever-important renin-angiotensin-aldosterone system, focusing on medications that affect this system. This is a critical system, ladies and gentlemen. I am telling you, you need to know about this not only for USMLE Step 1, 2, and 3, but for clinical practice. If you're somebody that kind of looks at the physiology and says, "Oh, I'll just try to remember medicine without learning the hardcore stuff," this is a place where you want to make an exception. You want to know this system inside and out because this system keeps us alive. And some of the most common medications that you prescribe, like ACE inhibitors, lisinopril, captopril, they affect this system. And so you'll want to know this system because understanding the building blocks, understanding the foundation of these basic sciences will give you a more intuitive and holistic understanding of why we do the things that we do. So, if you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. If you can consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll also have access to some of my premium videos in which I go over case reviews, how to formulate a differential diagnosis and treatment plan, things that will come in handy for you as you get ready to study for Step 2 CS or for Step 3, and also for clinical practice. So thank you very much in advance for your support. So the renin-angiotensin-aldosterone system, we're going to cover physiology first. Remember that this system keeps us alive, so you want to understand this system. Please, please, please come away with an understanding of this system, because if there's anything I can convey to you in all of my videos, this is one of the most important things that you can know, and it's going to gain you a ton of points on the USMLE if you can understand this system inside and out. You'll want to know about the ACE inhibitors, and we'll talk about that. These are the most common medications of these three classes that we're going to talk about. And they work on this system. We'll talk about the angiotensin receptor blockers, which work similarly to the ACE inhibitors, but at a different point in the system. And then we'll talk about the renin inhibitors. There's really only one that's on the market here in the US, but I put plural here just to make it consistent. And then we'll do a couple practice questions just to kind of make sure that we're on the right page with our knowledge, and then we'll recap. So this is the renin-angiotensin-aldosterone system. It looks very complex, but if we break it down piece by piece, it should be a little bit more easy to understand. So let's say that you, let's start out from the very beginning, right? And you have the liver, and the liver makes a protein called angiotensinogen. And it doesn't really know why it makes angiotensinogen, it just does. So you have your liver makes angiotensinogen. Angiotensinogen doesn't really do anything, it's just there. And let's say that you go a few hours without having any water. So 5-6 hours, you don't have anything to drink. What's going to happen to your plasma volume? It's going to go down. And as it goes down, your blood pressure is going to go down. When your blood pressure goes down, perfusion to your kidneys go down, because perfusion to your kidneys is based on your blood pressure. If you have low blood pressure, you have low perfusion. When your kidney senses that there is less perfusion, it's going to spit out an enzyme called renin. And renin is an enzyme that will convert angiotensinogen, and it'll chop off a tail off of angiotensinogen and convert it into a protein called angiotensin 1. And that is the only thing that renin really does for our purposes. Angiotensin 1 itself does not do anything. Angiotensin 1, in order to do something useful, needs to be converted into angiotensin 2. And we have an enzyme that does that, and that is called ACE, angiotensin converting enzyme, and this sits on the surface of your lungs and on the renal endothelium, but it's there. So angiotensin 1 gets converted into angiotensin 2, and angiotensin 2 can actually do stuff. So angiotensin 2 will interact with receptors on various target organs. One of the first things that it does is it promotes sympathetic activity. So it works directly on the sympathetic nervous system, and what it's doing is it's increasing the release of epinephrine and norepinephrine from the adrenal medulla. It's also working directly on the sympathetic nervous system by increasing the release and decreasing the reuptake of norepinephrine at the adrenergic nerve terminals. But this is a relatively minor role of angiotensin 2 compared to some of these other things. The big role of angiotensin 2 is tubular reabsorption and excretion. So angiotensin 2 is going to increase your reabsorption of sodium. And what does that mean? Well, anywhere sodium goes, water is going to follow. So sodium gets reabsorbed and so does water. And that's a good thing, right? Because if your blood pressure is low, if you got poor perfusion to your kidneys because you're not drinking enough, what do you want to do? You want to hold on to more fluid because that's going to keep your blood pressure up. And so you pull out sodium and put it back into your blood. And that's going to come at an expense because sodium has a positive charge. And in order to keep things electroneutral, you need to kick out something with a positive charge. And that's going to be potassium. So potassium is going to be excreted. So what all this means, though, is that we're holding on to more water. So sodium comes in and potassium goes out, and along with the sodium comes the water, and that's the most important thing that the angiotensin 2 is doing. Another way that you can do this same exact thing is that the angiotensin 2 is going to cause your adrenal cortex to secrete aldosterone, and aldosterone does the same exact thing. It promotes the reabsorption of sodium at the expense of potassium, and this helps us maintain fluid volume. Another thing that angiotensin 2 does is it causes arteriolar vasoconstriction, and this is going to increase your blood pressure to some degree. And then one more thing that it does is works on the pituitary gland, and that promotes the release of ADH, which also is going to help you hold on to more water. But this is the most important thing that it does here. Angiotensin 2 causes the release of aldosterone, and it also directly stimulates tubular sodium reabsorption and water retention at the expense of potassium. So let's talk about a couple things that can work here. We're not going to talk about these particular medications, but the beta blockers. So the beta blockers and clonidine actually cause the liver to release less angiotensinogen. So that's something we don't think of a whole lot, and it's really a minor role of these medications. But the fact that it does those things, even though it's not the primary mechanism of action of why we give these medications to reduce blood pressure, it does still nonetheless do this, and this is a minor role in its ability to lower blood pressure. So obviously if you have less angiotensinogen in your bloodstream, you're going to have ultimately less angiotensin 2 in the bloodstream. But this is just a piece of trivia, really, but it is something that the beta blockers and clonidine do. It reduces the amount of angiotensinogen in the blood. There is a medication called aliskiren, and aliskiren is a renin inhibitor. So what this means is that it blocks the effect of renin. And renin, remember, is an enzyme that is our very first step, the rate-limiting step in the ultimate production of angiotensin 2. So by blocking renin, you prevent angiotensinogen to be converted into angiotensin 1. So this directly inhibits the renin that is released by your kidney in response to decreased renal perfusion. Then, of course, there are the ACE inhibitors. Now, we talked about ACE being indispensable in the conversion of angiotensin 1 to angiotensin 2. But there is one more place where ACE works. And ACE actually has a role in that kallikrein-kinin system, which I talked about in one of my older videos that I made a while ago on hereditary angioedema. And what the kallikrein-kinin system is it's a system that your body uses to cause inflammation, induce inflammation. And we don't really think of this system a whole lot aside from disorders, and that's fine. It's a more obscure system, but this is a place where that kallikrein-kinin system comes in. In particular, you have a protein called bradykinin, and bradykinin, as part of the natural process, will get deactivated and converted into inactive metabolites. And it's actually the enzyme ACE which does this. You don't want to have too much bradykinin accumulating in your blood because bradykinin is an inflammatory mediator. It promotes the release of prostaglandins and nitric oxide. And so you want to in the course of homeostasis, you want to keep your bradykinin levels in check. And ACE is an enzyme that will do this. So if you inhibit ACE, you're going to have more bradykinin sitting around, and that can lead to problems in terms of inflammation. And we'll see this is one of the major side effects of the ACE inhibitors. The angiotensin receptor blockers, they just directly block angiotensin 2 at their receptor site. So you're just blocking the effect of angiotensin 2. So this is a more direct approach as opposed to the ACE inhibitors, where we are focused on the conversion of angiotensin 1 to angiotensin 2, reducing the production of angiotensin 2 before it even has a chance to work on its receptors. Angiotensin receptor blockers, they block the receptor. Okay, so the ACE inhibitors. ACE inhibitors block ACE, and this results in a decreased conversion of angiotensin 1 to angiotensin 2. Remember that ACE also degrades bradykinin, so if we block ACE, we're going to have more bradykinin in our system. Angiotensin 2 has widespread physiologic activity interacting with various angiotensin receptors, AT1 and AT2. We're primarily here concerned about the AT1 receptor, but there are two different types of angiotensin receptor blockers. So at the adrenal cortex, it's going to increase aldosterone secretion, which promotes sodium retention and potassium excretion. At the vasculature, it promotes vasoconstriction. At the adrenal medulla, it increases the release of epinephrine. With the sympathetic nervous system working directly on the nerves, it increases the release and decreases the reuptake of norepinephrine, and it does have a mild positive inotropic activity on the heart. So what does all this mean? Well, when we have an ACE inhibitor, it's going to do the opposite of all this. It's going to induce the opposite. So it's an ACE inhibitor, by reducing the amount of aldosterone that is in the system, it's going to promote sodium excretion along with water and potassium retention. So hyperkalemia is a possibility with ACE inhibitors. You got to be careful if you have a patient who is on potassium supplements, that maybe they go off those potassium supplements before starting an ACE inhibitor. It's going to cause a mild degree of direct vasodilation. It's going to reduce the amount of epinephrine and norepinephrine in your system, and really this effect on the heart is relatively mild. So the major effect of ACE inhibitors is that it promotes sodium excretion, and by virtue of that, you're going to get rid of some water, and it also causes a mild vasodilation as well. So those two things are going to lower your blood pressure. Some examples of ACE inhibitors: anything ending in pril. So enalapril, captopril, lisinopril, very commonly prescribed medications. ACE inhibitors, they do need to be converted into an active metabolite by hydrolysis in the liver, so they cannot be given IV. They need to be given PO. There is an IV formulation of ACE inhibitors. I can't remember what it's called exactly. I've never actually used it, to be honest. But it ends with prilat, P-R-I-L-A-T. One of you can go look it up and write it down in the comments below. But there is a formulation of ACE inhibitor that can be given IV, and it's just in its active form. So ACE inhibitors have the effect of reducing both the preload and the afterload. It reduces the preload because of its mild diuretic effect. It reduces the amount of sodium and water reabsorption. It also reduces the afterload because of its mild vasodilatory effect. It reduces the pressure that the heart needs to pump against. And for this purpose, it's very good for mild to moderate hypertension. And that is by far the most common reason that ACE inhibitors are given out. Very, very, very good drug for hypertension. So mild to moderate hypertension. It also improves survival after an MI by reducing the amount of stress on the heart. And so this is very commonly and needs to be given after an MI, and it does improve survival along with the beta blockers. It's commonly given to patients with diabetes because of its renal protective effects. And the reason here is what we're doing is we are reducing the amount of, it does reduce the amount of perfusion to the kidneys, but what it does is it reduces the amount of pressure in the kidneys. And so what's happening here is that we are reducing the stress on the kidneys. Even though, yes, it does mildly reduce your renal function, and so your creatinine may go up a little bit, the overall effect is positive for the kidneys. By reducing the amount of pressure and workload in the kidneys, it has a protective effect for the kidneys. Even though the kidneys slack off a little bit and your creatinine goes up, it's not enough to really hurt you. So it kind of takes a load off the kidneys, so to speak. And so it's commonly given in patients with diabetes, especially hypertensive patients with diabetes, to prevent the progression or the onset of diabetic nephropathy. And then it's commonly given in congestive heart failure because of its reduction on the afterload. So these are common uses for ACE inhibitors. Adverse effects. Dry cough. By far the most common adverse effect is a cough. Many patients will tell you if you ask them, okay, I've started you on an ACE inhibitor last month, how is it going? Do you have any cough? If you ask them, they'll probably say, yeah, I have been coughing a little bit more than usual. For most patients, this is not going to be a big enough deal to go off of the medication. ACE inhibitors are such good medications. We want to keep patients on these if we can. However, there will be a small minority of patients who will come in and say, Doc, I've had this cough. It's not going away. I can't stay on this. And those patients, then we will want to switch them to an angiotensin receptor blocker, which we'll talk about in a little bit, does not have the effect of causing this cough. Then there's angioedema. This is not a very common adverse effect. It affects only about 0.1 to 0.5% of patients who are placed on ACE inhibitors, but it is life-threatening. And as you can see, angioedema is nothing to shake a stick at. So angioedema, classically, they come in swollen lips, swollen eyes, swollen tongue, and obviously what we're worried about here is respiratory failure, because they're not going to be able to ventilate properly because they're obstructed. You can see a big problem here. So why does this happen? Well, it goes back to that kallikrein-kinin system. You have bradykinin. Bradykinin gets deactivated by ACE. If we inhibit ACE, then we're increasing the amount of bradykinin that's laying around, and that can cause an angioedema in some patients. But most patients, it won't happen. Okay. So that's something that you'll want to be aware of. This will come up on the test. I can almost guarantee you'll get a question about the adverse effects of ACE inhibitors, and it's probably going to be about angioedema, just because it's so commonly tested. So I really implore you to remember this, and it has to do with bradykinin. Just like the cough, I think that has something to do with bradykinin, but I'm not sure there. We do know, though, that ACE sits in the lungs, so that may be the mechanism behind that cough. But with angioedema, it is bradykinin mediated, and so that's why you get angioedema. This will come up on the test. Hyperkalemia. Of course you can get hyperkalemia. Why? Because you are reducing the amount of sodium reabsorption, and so by virtue of that, you need to increase the amount of potassium reabsorption. It's kind of a zero-sum game that you're playing. So for this reason, a lot of times ACE inhibitors will be given with thiazide diuretics, and thiazide diuretics have the effect of kicking out potassium. It works on a different channel in the nephron, but both loop diuretics and thiazide diuretics cause you to lose potassium. So if you combine a medication that causes you to retain potassium with a medication that causes you to lose potassium, you can kind of cancel those out. And so a lot of times you'll see like lisinopril, hydrochlorothiazide combined. And that may be given immediately, or it may be given as you start on lisinopril, for instance, and then the patient has not adequately responded to that, their blood pressure is still high, you can add hydrochlorothiazide onto that. We're not going to talk about the diuretics here, but you'll see that commonly given. And then acute renal failure in patients with renal artery stenosis. Now, I should add here, but really we're talking about bilateral renal artery stenosis. It's controversial as to whether we should give ACE inhibitors for patients who just have renal artery stenosis on one side, unilateral renal artery stenosis, but absolutely ACE inhibitors are contraindicated for patients with bilateral renal artery stenosis. Why is that? Well, when you have bilateral renal artery stenosis, which I'm just going to call renal artery stenosis, what's happening is that the only way you get real good perfusion at all to your kidneys is that you increase the efferent arteriolar tone. Okay, it kind of works like a sink. And so what you're doing is you're increasing the arteriolar tone, and that's going to keep that pressure high enough. So what's happening already is that you have low perfusion pressure because you have a stenosed renal artery. So there's less blood going to the kidney. And your kidney's way of keeping that pressure up at an adequate amount to drive what your kidney is supposed to do is to constrict that efferent arteriole. And so what happens when you give ACE inhibitors is that now you're dilating that renal arteriole. And so when you dilate that efferent arteriole, now you have low amount of blood along with a dilated artery, or relatively dilated artery. And so what's going to happen to perfusion pressure? It's going to plummet and go through the floor. And now your kidneys are not working. And so you're going to have acute renal failure in any patient you give an ACE inhibitor to who has bilateral renal artery stenosis. So bad idea. Always make sure you check for renal artery bruits before you give an ACE inhibitor. And then severe hypotension is a possible adverse effect. If you give too high a dosage, you can certainly cause hypotension, especially if they're not drinking. And by drinking, I'm talking about drinking water, not drinking alcohol here. But drinking alcohol would certainly cause hypotension because it is a diuretic. And then rash and fever are possibilities pretty much with any medication. Contraindications, as we already talked about, renal artery stenosis, pregnancy. Absolutely no ACE inhibitors in pregnancy. Why? Because it reduces the amount of amniotic fluid, oligohydramnios. It interferes with the development of the kidney in the neonate, and also has the effect of interfering with bradykinin. And bradykinin is responsible for closure of the ductus arteriosus. And so if you give an ACE inhibitor to a woman who is progressed in her pregnancy and she's still taking it, along with all these fetal malformations that you can also have a baby with a patent ductus arteriosus. So for all those reasons, we don't give ACE inhibitors in pregnancy. If you need to lower a woman's blood pressure and she's pregnant, you want to give her something like methyldopa or labetalol, much safer. And then angioedema, which we already talked about. If they have a history of angioedema with one ACE inhibitor, we're not going to give her any ACE inhibitors. Those are categorically contraindicated for patients with angioedema from an ACE inhibitor. We don't give them any ACE inhibitor. You can probably give them an angiotensin receptor blocker, but you'll want to make sure and observe them first. There is some evidence that ACE inhibitor-based therapy for hypertension may not be sufficiently effective for improving cardiovascular outcomes in African American patients. And why is that? Well, it just so happens that African American patients tend to have a relatively low renin level when they're hypertensive. So whereas for everybody else, their renin levels are a little bit higher when they have hypertension, with African American patients, and really here you can probably summarize this to most black patients, although the literature I read was specifically referring to African Americans. It's probably not going to be as effective because it's probably not the renin-angiotensin-aldosterone system that's really driving their hypertension. So just giving them an ACE inhibitor is probably not going to have the same degree of effect as if you were to give it to a white person or to a Hispanic person. And so many cardiologists, nephrologists will prefer to give a calcium channel blocker and diuretic as the basis of therapy as opposed to an ACE inhibitor. But there's some controversy about this. I got this from one particular article from the Journal of the American College of Cardiology. But this jives with a lot of what I've seen in my practice, that ACE inhibitors really aren't as good for African Americans as they work for everybody else. And so you may want to consider a different route of therapy for those patients. And it also so happens to be that the risk of angioedema as a side effect of ACE inhibitors is higher in patients of African descent. And I believe this sums out to all patients of African descent, not just African Americans. It's actually up to 5 times higher. So here now we're talking about a 2% risk as opposed to about a 0.5% risk in everybody else. So another reason why we may want to think twice about giving ACE inhibitors to patients of African descent. But like I said, there's controversy about that. You may find different things depending on where you go. But like I said, I prefer this because I read this in the literature, and it also jives with my personal experience in the clinic. So angioedema here, you should have a good idea of what this looks like. Classic USMLE question, you have a patient with angioedema, you get a list of their medications. Which of the following medications most likely cause this? You know the answer now. So angiotensin receptor blockers. This is a different class of medications, but it works really in a similar way. However, as opposed to blocking ACE, here we're blocking angiotensin II directly. So ACE inhibitors prevented the production of angiotensin II from angiotensin I. Here we're directly blocking angiotensin II at its target site. So it has a similar spectrum of action to the ACE inhibitors, because with the ACE inhibitors we're preventing the production of angiotensin II, and here we're just blocking the activity of angiotensin II. So you can see how they're very similar. They have a similar spectrum of action because they work very similarly. They are also contraindicated in pregnancy and in renal artery stenosis because with pregnancy we are worried about affecting the development of the kidneys in the fetus and causing oligohydramnios. We are also concerned about giving angiotensin receptor blockers in patients with renal artery stenosis, as you can imagine, for the same reason we're concerned about ACE inhibitors. Renal artery stenosis, their renal function is entirely driven on the constriction of that efferent arteriole. And so if we give something that's going to cause dilation of that arteriole, then we can entirely collapse their renal function and cause an acute renal failure. Their creatinine will go through the roof, and you'll have a problem on hands. So again, before you give something like an angiotensin receptor blocker, just like an ACE inhibitor, listen for a bruit. You get the similar benefits for angiotensin receptor blockers as you get in ACE inhibitors for patients with heart failure and for chronic kidney disease. But you want to make sure before you give an angiotensin receptor blocker to a patient with chronic kidney disease, you do want to make sure that they have adequate renal function. So there is a threshold in which we would not want to give any of these medications to a patient if their renal function is diminished to a particular degree. You will not be asked about that on the test. Angiotensin receptor blockers should be reserved for cases in which ACE inhibitors are not tolerated, so patients with cough or angioedema. And they'll be a little bit better as far as not causing those side effects because you're not inhibiting ACE. So you are still, you still have ACE activity, so you're not going to build up bradykinin, and that's probably going to diminish the risk of that dry cough and angioedema. However, there is still some risk of angioedema. And as a matter of fact, if you give an angiotensin receptor blocker to a patient who had an angioedema with an ACE inhibitor, you have about a 2 to 17% recurrence rate. Now, these medications are so good at reducing blood pressure and improving survival with heart attack and stuff like that, that we really do want to give these medications. And so what you'll probably do is you'll just observe these patients. If they had angioedema, you can give them the angiotensin receptor blocker and observe them for a little while, make sure they don't develop angioedema. Just give them, some fair warning that if you start to have any, tingling in your lip or tongue, the least bit of swelling, go immediately to an ER. But for the vast majority of these patients, even the ones with angioedema on the ACE inhibitors, they'll be completely fine on the angiotensin receptor blockers. Some examples of the angiotensin receptor blockers include losartan, valsartan, and candesartan. Okay, and then we got the renin inhibitor. So the renin inhibitor is aliskiren, and you do not hear about this medication a lot because it's kind of controversial and there's some major drawbacks to it. It's certainly not the first medication you're going to go to ever. So the renin inhibitor aliskiren inhibits the enzyme renin, and that is the enzyme that converts angiotensinogen into angiotensin I, which is the rate-limiting step in the renin-angiotensin-aldosterone system. Like I said, there's some controversy regarding the actual benefits of aliskiren. It may increase the risk of adverse cardiovascular events in patients with diabetes. So this will not be the first medication you go to. Adverse effects of the renin inhibitor aliskiren are hyperkalemia, renal impairment, and hypotension. The contraindications are the exact same as for the ACE inhibitor and the angiotensin receptor blocker. We do not give to pregnant patients or patients with renal artery stenosis. Okay, so let's test our knowledge with a review question. Which of the following is true about captopril? A, it decreases the serum angiotensin 1 concentration. B, it increases the serum angiotensin 2 concentration. C, it increases the serum sodium concentration. D, it increases the serum potassium concentration. E, it decreases the serum renin concentration. Or F, it increases the conversion of bradykinin to inactive metabolites. Okay, I'll give you a chance to pause it here. And now I will tell you the answer. It is D. It increases the serum potassium concentration. So what is captopril? And this is a classic USMLE style question. It gives you a drug, wants you to know what it does. What's captopril? Captopril is an ACE inhibitor. So what does an ACE inhibitor do? It inhibits ACE. What does ACE do? It converts angiotensin 1 to angiotensin 2. Now, if you lower blood pressure, and that is what ACE inhibitors do, can we agree on that? Yes. So ACE inhibitors lower blood pressure, and if you lower blood pressure, what's going to happen to your renin concentration? It's going to go up. So you lower blood pressure, your renin concentration is going to go up because you're mildly decreasing the perfusion to the kidneys, and that's going to cause your renin concentration to go up. Your kidneys sense that it's getting less blood or that the perfusion pressure is down. So renin concentration goes up. So that eliminates E. As the renin concentration goes up, the amount of angiotensin 1 is going to go up because it cleaves angiotensinogen and produces angiotensin 1. So the angiotensin 1 concentration is going to go up. So that eliminates A. It's also going to, so you give the ACE inhibitor, right? You have a higher concentration of angiotensin 1, but the ACE inhibitor blocks the conversion of angiotensin 1 to angiotensin 2. So if you're giving an ACE inhibitor, your angiotensin 2 concentration is not going to go up, it's going to go down because you're blocking the production of it from angiotensin 1 to angiotensin 2. So B is going to be eliminated. So now we're down to C, D, and F. Well, we know that if we have less angiotensin, well, what does angiotensin 2 do? So angiotensin 2 causes the release of aldosterone. And so if you have more aldosterone, you're going to retain sodium and you're going to lose potassium. You're going to be excreting potassium. So if you're retaining sodium, your sodium concentration is going to go up. If you're excreting potassium, your potassium concentration is going to go down. Now, if we're giving an ACE inhibitor, we're doing the opposite. So your sodium concentration is going to go down and your potassium concentration is going to go up. And remember that one of the side effects of ACE inhibitors is hyperkalemia. So just knowing that, you should be able to answer D. D is the correct answer. So C is not right because your sodium concentration is going to go down. Remember, anytime your sodium concentration goes up, you're going to retain more fluid in you're going to have more intravascular volume. So it's certainly not C. And then just for completion's sake, why not F? Increases the conversion of bradykinin to inactive metabolites. What converts bradykinin into inactive metabolites? What enzyme does that? It's ACE. ACE converts bradykinin into inactive metabolites. So if you inhibit ACE, which captopril does, you're going to have decreased conversion of bradykinin to inactive metabolites, and that is why you can get angioedema. All right, how about this one? A 59-year-old African-American woman with newly diagnosed essential hypertension is being treated with lisinopril and lifestyle modifications, including a weight loss regimen. Fasting blood glucose is 77 milligrams per deciliter. Which of the following is true about her situation? A, losing weight will not improve her blood pressure. B, evidence suggests that she will respond best to monotherapy with an ACE inhibitor at this point. C, evidence suggests that her blood pressure may be better controlled with a calcium channel blocker and a diuretic. D, African American hypertensives tend to have higher renin levels compared to white hypertensives. Or E, African Americans have a lower risk of ACE inhibitor-induced angioedema. We talked about this in our talk, so let's see if you've been paying attention. All right, our answer here is C. Evidence suggests her blood pressure may be better controlled with a calcium channel blocker and diuretic. So first off, why not A? So losing weight will not improve her blood pressure. Does losing weight help with your blood pressure? It most certainly does. A 10-pound weight loss can actually have the effect of eliminating hypertension if you have very early mild hypertension. Mild weight loss, getting it, well, I should say, it's been said that a 10-pound weight loss can really make a big difference, but I would say getting into the normal, getting to a normal weight range will have the best effect. But just losing 10 pounds can have an effect on your blood pressure. So certainly losing weight will improve her blood pressure. Is it going to cause a patient who has hypertension to now no longer have hypertension? Maybe, maybe not. But losing weight will certainly improve her blood pressure to some degree. So A is out. B, evidence suggests that she will respond best to monotherapy with an ACE inhibitor at this point. The answer to that is probably not, because she's an African American, and we know from the literature that African Americans are less likely to respond to ACE inhibitor monotherapy than they are to an ACE inhibitor with some other medication like a beta blocker, a calcium channel blocker, or even an ACE inhibitor with a diuretic. ACE inhibitor does not really do a whole lot for African Americans compared to everybody else. So maybe she will respond to ACE inhibitor monotherapy. If her hypertension is really not that bad, she may be fine. But the evidence suggests that she's going to have a harder time on the basis of her race responding to an ACE inhibitor than a white person or a Hispanic person, for instance. Okay, why not D? Well, we already talked about this. African American hypertensives tend to have lower renin levels, and that's why the drugs that affect the renin-angiotensin-aldosterone system tend to not work as well for African Americans compared to everybody else. So that's why we prefer to give other medications that don't affect that system, that reduce the blood pressure in a different way, that use different mechanisms. And then E, African Americans have a lower risk of ACE inhibitor-induced angioedema. That is patently false. They have a 5-time higher risk of angioedema from ACE inhibitors. So the answer is, in fact, C. Evidence suggests that her blood pressure may be better controlled with a calcium channel blocker and a diuretic. So Norvasc amlodipine is the one that I've seen most commonly used with preference for African Americans. So to recap, ACE inhibitors and angiotensin receptor blockers are commonly used in the management of mild to moderate hypertension, especially in the setting of diabetes because of its renal protective properties. It reduces the risk of or delays the onset of diabetic nephropathy. That's why it's given in diabetes. And there is some evidence saying that ACE inhibitors are good to give pretty much to anybody with diabetes, even if they don't have hypertension, but that's controversial. It reduces the mortality in post-MI patients, so this will be part of your standard regimen for patients who have just suffered a heart attack. It may be combined with a diuretic, especially hydrochlorothiazide. Benefit to that is that hydrochlorothiazide, thiazide diuretics, loop diuretics, they cause you to lose potassium. And so that's, aside from the fact that adding a diuretic to an ACE inhibitor is going to augment the hypotensive effect of the two medications, you're also going to you may offset some of that potassium, those potassium issues. Whereas an ACE inhibitor causes you to retain potassium, hydrochlorothiazide, for instance, will cause you to lose potassium. Major adverse effect of ACE inhibitor is angioedema. It's certainly not the most common side effect, but it is a major adverse effect. Patient can be switched to angiotensin receptor blocker under close supervision. Other adverse effects of ACE inhibitors and angiotensin receptor blockers are a dry cough. That's more going to be associated with the ACE inhibitors, but you can rarely see it in the angiotensin receptor blockers for reasons that elude me. Also, postural hypotension, also known as orthostatic hypotension, and hyperkalemia. Why is it going to cause postural hypotension? Just because these medications, by reducing the amount of angiotensin II, it's going to have a mild vasodilatory effect. And it reduces your blood pressure, so it puts you at risk for hypotension. And then the ACE inhibitors and angiotensin receptor blockers are absolutely contraindicated in pregnancy. You will never give these to a pregnant woman. They are like poison for a pregnant woman, more for her baby. So you do not give these medications. Like I said, if you're treating a pregnant woman with hypertension, you're going to be giving her something like methyl-dopa or labetalol. ACE inhibitors and angiotensin receptor blockers are contraindicated in pregnant. I already said that. And patients with bilateral renal artery stenosis. Why do we avoid these in patients with bilateral renal artery stenosis? Because their kidneys are dependent on those tight vessels in their kidneys. It maintains their perfusion pressure. If you dilate those vessels, which ACE inhibitors and angiotensin receptor blockers will do, it will dilate those vessels. You completely collapse their renal perfusion, and they will have immediate acute renal failure, and that can be catastrophic. So you do not give ACE inhibitors and angiotensin receptor blockers in patients with bilateral renal artery stenosis. And that is all I have for you. I hope that this helped you with your understanding of the renin-angiotensin-aldosterone system and some of these common medications, including ACE inhibitors and angiotensin receptor blockers. I will see you next time.